Hi guys, welcome back to week 11, module 11. Here we are discussing neurological disorders of the adult, evaluation and management of. In this particular lecture, we're going to focus on the most common neurological complaints in your readings. That's what you focused on in chapter 6, common neurological complaints, and chapter 7 was seizure disorders. In your cash book, you looked at a lot of the guidelines for a lot of the basic things such as Alzheimer's, Parkinson's, headaches, seizures, strokes, vertigo, those kind of things. We'll go over a lot of that here in our lecture today. It's not a very long lecture. I did include one video just to review the basics. So here we go, guys. Okay, so I just wanted to start with a very basic review of the actual neurological exam so we can really apply a lot of these basic complaints into how we would actually examine them in practice. This is the Merck Manual professional version. It's a very condensed 4-minute neurological exam just to give you an idea of, what you would do in a basic overall physical if you had any neurological concerns about your patient. And then he talks about, how you would take it a step further if there were abnormalities that you did find. Here we go. It's a very short video.
The fundamentals of the neurological exam can be completed in about 4 minutes, yet still detect deficits in any of the major components. Normal findings are reassuring. Abnormal findings should trigger a more detailed exam of that component. To maximize efficiency, components may be done out of the standard sequence. Careful wording of commands and demonstration by the examiner as commands are given speed the exam and minimize difficulties due to deficits in hearing, cognition, and language comprehension.
Just look at my nose. How many fingers?
4.
Good. How many now?
2.
Good. Just keep looking at me for a minute. I'm going to shine my light in your eyes. Great. Stay with me. Good. Now watch the light and just follow it as it moves. Up and down and up. Very good. Look at me again. Show me a big smile. Good. Stick your tongue out. Very good. Shrug your shoulders up. Great. Good. Now I'm going to whisper a number in your ear. You just tell me the number.
6.
Very good.
4.
Very good. Arms out in front. Palms to the ceiling. Close your eyes, please. Good. You can open your eyes. Give me a hard squeeze. Really good. All right. Great. Arms up. Don't let it play down. Be strong. Good. Strong on this side. Good. Now push me away. Good. Push me away. Very good. Nice and relaxed for a minute. Real loose. Great. Real loose. Good. Take this hand and tap very fast. Good. The other one. Very fast. Good. Take that finger and touch your nose and then touch my finger. Go back and forth and back and forth. Good. With the other hand, do the same. Very good. Excellent. All right. Now hold on to the stretcher. Hike your knee up to my hand. Keep it up. Strong. Good. Bring this one up. Be strong. Good. All right. Okay, push me away. Great. Push me away. Very good. Bring your foot up. Cock your toes up toward your head. Don't let me push you down. Be strong. Very good. On the other side. Strong. Hold them up. Very good. All right. Now, so what I'm going to want to do is I'm going to hold your foot up. I want you to put your heel on your knee and then make a straight line down your shin. Very good. Excellent. Do the same thing with the other. Great. Now, I have to scratch the bottom of your foot. It's annoying. Sorry.
That is.
All right. There you go. Okay, very good. Now, I just want to see how you feel things. All right.
Okay.
So I have a piece of cotton here. I'm going to take that piece of cotton. Just tell me, are they about the same? Roughly
Yes,
the same?
the
Good.
same.
About here and here, roughly the same.
Same.
Here, here, and here, roughly the
same.
same. Now, this will be a little bit sharp.
Okay.
Is that sharp?
Not
Roughly
sharp,
the same?
yes.
Good. Here?
The
Roughly
same.
the same. Here? Roughly the same.
same.
Very good. I have a tuning fork, makes
Okay.
vibration, buzz, and buzz. About the same.
Same.
Good. And here, and here. Roughly the same?
The same.
Good. I'm going to touch your right hand, your left hand, or both. You just tell me what.
Okay.
Eyes closed. What I touch.
Both.
Good. Very good. You can open your eyes. I'm going to just tap you here. I want you to be nice and relaxed, okay?
Okay.
Nice and relaxed. That's great. Just like you're doing. Perfect. Nice and relaxed. Good. All right, very good. Can you come on down on the floor and just stand? All right. Now bring your heels together like a soldier at attention. Eyes closed. Don't let me push you over. Very good. You can open your eyes. Can you just walk over about 5 feet? Good. And come on back. Good. A couple times fast, as if you're trying to catch a bus. Back and forth, back and forth. Good. Stop. All right. Stop. Walk backwards. Stop. Come forward. One foot right in front of the other. Heel touching your tongue. Great. Have a seat back there. I need to ask you a few questions just to check on your thinking, and then we're all done.
Okay.
So what day is it today?
Today is Monday.
Great. And how about the date?
It is June 7th.
Very good. And what year?
2015.
Good. I'll spot you a day. That's all right. Who's our president?
Obama.
And what's going on in the news? Any topic you want.
What's going on in the news? The basketball playoffs are going on.
Okay. Very good. Can you put your right pointing finger on your left ear? Do that for me. Good. You can bring it down. How much is 20 multiplied by 30? I'm saying 20 times 30.
600.
Very good. There's an old saying that goes, don't put all your eggs in one basket. What is the point of that?
Don't put everything. You might lose the chance to do something different.
Very good. What are these things?
They're glasses.
What part of the glasses do I actually look through?
The lenses.
Very good. Say after me. No ifs, ands, or buts.
No ifs, ands, or buts.
Okay. Apple, pear, and peach. What are they?
Fruits.
Bed, table, and chair.
Furniture.
Excellent. Good. Thank you very much.
Okay.
So that, even though it was only like 5-6 minute exam, it was incredibly thorough, and you guys will get good at that with a lot of practice. He did do it quite quickly, even though that was pretty much a very basic neuro exam. And it's so important though that you're competent in that exam, because you can get through it quickly, because to be quite honest with you, in your assessment times that you're allotted during your practice, it's not a lot of time. So you really have to try to get through those things as efficiently as possible. Okay, hopefully that was helpful. So now let's just get into the basic common neurological complaints. So one of the biggest first things we see are confusion. So you notice at the end of that exam, he went into just to examine her for any cognitive deficits. So just keep in mind, confusion is not a disease process or a disease state, but rather a symptom. It's the inability to think quickly or coherently, and it's a key sign of neurological disorders. One major difficulty lies in differentiating symptoms of delirium from dementia. And causes could be delirium, dementias, metabolic, infectious processes such as a UTI. Remember, in our elderly patients, one of the first things we question when we see a change in mental status or an increase in confusion is, does the patient have a UTI, right? Infectious processes. Hypoxia and ischemia. Dementia or delirium. So how do we differentiate? So dementia is a decline in mental functioning affecting memory, cognition, language, and personality. Acute transient disturbance in thought process is a result of delirium. So delirium comes on quickly. It's acute, it happens suddenly, and it's transient disturbance in thought process. So it's sometimes called an acute confusional state. Whereas persistent or more severe confusion with or without psychomotor hyperactivity characterized by significant time span between symptom appearance and death, defines dementia. Patients with a history of dementia have a higher incidence of delirium, whereas delirium may also exist as a state by itself without any evidence of dementia. So keep in mind, delirium comes on quickly, and sometimes can disappear quickly, how unlike dementia, which comes on kind of slowly and it does, just progressively gets worse at a certain point. So just keep that in mind, that you need to make sure you're able to differentiate the two. If you want to look for more defining characteristics of the two different things, you can look at your Dunphy chapter 6, table 6.1. So here's an algorithm to really get you through the process of assessing confusion appropriately and figuring out, what is what. So if we think it's an infectious process, then we look at things such as pneumonia, encephalitis, meningitis, brain disease, neoplastic disease, urinary tract infection, septicemia, and anaphylaxis, right? If we think it's a metabolic disturbance with fluid and electrolytes or acid-base imbalances, we look at the kidneys, we look at hypoxemia, seizures, any kind of respiratory concerns, thyroid disorder, hypoglycemia, all right? So there's a lot of reasons for confusion. Make sure you differentiate which one is which in terms of what your patient is presenting with, because that will really make a big difference in your diagnostic and treatment plan. And we don't want to wait with confusion. Confusion can sometimes turn into something bad very quickly. So you really want to try to narrow down what the reason is for the confusion, the cause. So dizziness versus vertigo. Dizziness encompasses a variety of abnormal sensations relating to perceptions of the body's position or motion in relation to the environment. It's described as feeling lightheaded or feeling faint. It's due to the lack of blood flow. And FYI, dizziness presents in 50% of those patients who have a stroke or a CVA. So if you hear a patient with, symptoms that you're not really sure if it's a stroke or stroke or CVA, but they do present with dizziness, you may want to go ahead and rule that out. Okay. Vertigo is the most common. It's a false sensation of rotation or movement of surroundings. It's often due to inner ear issues. Both vertigo and dizziness can cause vomiting, nausea, and nystagmus, as well as a gait disturbance. So differential diagnoses are classified into 4 different categories of dizziness. Those include peripheral vestibular disease, systemic issues, CNS issues, and anxiety states. So again, here's another algorithm to help you differentiate the dizziness and vertigo and their baseline causes. So if we have dizziness and vertigo associated with an imbalance and disequilibrium, as well as visual changes, difficulty swallowing, numbness and tingling, then we want to do obviously a neurological assessment, a possible CT scan and an MRI to rule out vestibular dysfunction or cerebellar disorders or a CVA. If the symptoms are very vague and it's more related to stress and anxiety and possibly depression, we want to do a negative assessment and work up, and we want to possibly refer for psychiatric eval. So this is the way you have to think in terms of dizziness and vertigo. They're very broad complaints that are very common. So you really want to narrow down. Is it cardiac? Is it infection? Is it anxiety? The differentiating factors are very, very important. Okay, so in terms of peripheral vestibular causes, there are 3 common vestibular causes. The first one is vestibular neuritis, which lasts for days. It's unilateral inflammation of the cerebral nerve, vestibular nerve. It's similar to Bell's palsy, often though thought to be secondary to a virus. It's rare to have more than one occurrence. It's usually sudden and severe, lasts 1 to 2 days, and then lessens over 2 to 4 weeks. Ill appearing, the patient is very ill appearing, and they tend to lean towards the side of the lesion. The other ones are benign paroxysmal positional vertigo and Meniere's disease. So benign paroxysmal positional vertigo is brief in that it lasts less than 60 seconds, and the patient can have a disturbed sense of balance for several minutes. It usually occurs with head positional changes. It's very common in the elderly. Usually it's caused because of an inner ear disturbance where the otoliths are out of place. The next one is Meniere's disease. It's idiopathic. They don't really know what causes it, but it's most likely due to an excess of epilymph, or roaring tinnitus is unique to this problem. So a lot of ringing in the ears. These patients usually have a sensorineural hearing loss. And it's a very uncomfortable disease. With these patients, just make sure you're giving them a lot of support and seeing if they need any kind of assist at home. All right, so systemic and CNS causes of dizziness. So the systemic causes, you want to look for signs of anemia, cardiovascular disease with hyperventilation. You want to look for drug reactions, endocrine disorders, and psychiatric problems. In these particular patients, you may see pallor, like they become pale, a little short of breath, tachycardic, bounding pulse, weakness, hypotension, blurred vision, decreased breath sounds, headache, diaphoresis, and agitation all suggest systemic problems. If it's a CNS cause, CNS disorders that disrupt the pathway between the vestibular apparatus and the brain may cause dizziness. So you may see facial numbness, hemiparesis, diplopia, dysarthria, headache, nausea, and vomiting, which all suggest CNS dysfunction. So in terms of diagnosing, you have to understand the patient's definition of dizziness. So really make sure they clarify what dizzy means to them. Okay. You want to consider causes from the appropriate category based on the algorithm on the previous slides. Is it new? Is this dizziness the patient is experiencing? Is it new, or is this a recurrent problem that comes and goes frequently, and how often? Then you want to really fine tune how often, what are precipitating factors, that kind of thing. Of course, you want to look for associated symptoms. You want to do your diagnostic examination and treatment depending on the underlying disorder. You want to look at their past medical history. Does the patient have any history of head trauma, migraines, falls, prior dizzy? Was this patient in the service? Did they serve any military time across seas? Were they exposed to any gunfire, bombs, head injuries? Again, you want to ask about medications, of course, include illicit drugs, any drugs that they're using outside of prescribed medications. Also definitely want to find out how much they're drinking. And remember, you always want to be careful when you're asking about that, and be very clear that a lot of the times patients who are drinking, and especially if they drink a lot, are not giving you the honest amount that they actually drink. You also want to look in their history and their charts, see if there was any prior workup for this particular issue at any point. In your physical exam, you're assessing for postural orthostatic hypotension. You're going to do a brief head to toe exam with attention to cardiovascular and neurological function. You want to focus on the cranial nerves, do all cerebellar testing, assess for nystagmus, extraocular movements. You want to perform a Hell-Pike-Dix maneuver, and you want to be sure to do a tandem gait and assess truncal instability. Your role as an NP is to make sure you evaluate and differentiate between peripheral from systemic or CNS causes and treat appropriately, especially if it's an acute onset. Okay, headaches. We've got to talk about headaches, of course. Very, very common complaint in primary care. 50% of patients seen in primary care are tension headaches. So 50% of the patients who come in with headaches, the type of headache they're coming in with is a tension headache. So when in this particular diagram, it's very helpful because it really points out where the locations of headache pain are, if they're associated with which particular type. So here she is holding on to the sides of her head. This would be considered a tension headache. Migraine headache is usually often on one side of the head. See where the red is? So it's just on one side of the head, but sometimes the location varies. Cluster headache, it's just in small bouts, and it can usually around the temple areas. So in females, it's usually greater in females than males to be complaining of this particular symptom. It happens at all ages, but it peaks between the ages of 30 to 38 years old. 90% of headaches are not pathologic. And there's over a $17 billion cost in loss of wages and medical treatment for migraines. So keep in mind, we really want to try to treat this in our office to make sure it doesn't progress to something worse where the patient is losing work time. So we have a major classification of headaches. We have three types, or a few types: tension, migraine, cluster, and traction or inflammatory. Again, so important that you know how to differentiate and treat accordingly, because these questions definitely come up on the boards. So tension, migraine, and cluster are your major classifications. Traction/inflammatory headaches you don't see very often because that is an emergency and it's due to a hemorrhage. And again, if there's nothing else you learn from this lecture, the first thing I'm going to tell you is if a patient comes into you and says, I have the worst headache ever, that is an emergency. If some patient says that to you and is grabbing their head and is obviously in severe pain, you need to call 911. It's probably due to a hemorrhage. So remember those words: worst headache ever equals 911. Other subgroup types of headaches include exertional headaches, headaches associated with direct physical stimuli, epicranial headaches, and other hypnic headaches like sleep-related headaches that occur in the elderly. Okay, so here is your beautiful little diagram chart to give you some differentiation of the different types of headaches. So tension type headache with nausea and vomiting and bilateral pressure or band-like pain. Migraines, usually, like I said, unilateral. Sometimes they get nausea and vomiting as well with photophobia and phonophobia. Cluster headaches are periorbital, around the eyes, and sometimes it's unilateral, a lot of times at night. Again, photophobia, tearing, and nasal stuffiness. So here's our treatment plan. If it was tension type headaches, we're looking at aspirin, Tylenol, NSAIDs, muscle relaxants, massage, stress management. Okay, don't forget things outside of your RXs that you can prescribe, in terms of alternative things to help manage the stress and whatever issues the patient might be having in their life. In terms of migraines, in terms of treatment, you want to talk about avoiding things that are actually leading to the migraines, whether it's stress or certain people or situations. You also want to consider NSAIDs, triptans, antiemetics, propranolol, and nortriptyline. Cluster headaches, again, that also requires something stronger. Sumatriptan or indomethacin, as well as oxygen, can be very effective on cluster headaches. Okay, so again, here's a beautiful diagnostic reasoning algorithm specifically for headaches. Lots of different variables, locations, characteristics, and associated findings, which will give you a perfect, diagnostic reasoning to work with. So, the big ones I definitely like to point out are the meningitis. So usually there's headache associated with neck pain, fever, nuchal rigidity, like they can't move their neck. And it could just have been that they were exposed to infection. But again, those are really, it's a bad sign. So make sure you follow up if it is meningitis. Brain tumor associated findings would be papilledema, nausea, projectile vomiting, altered mental status. Again, things to really consider with headaches. Okay, there's so many thoughts that it could be a brain tumor, it could be migraine temporal arteriitis, very, very big deal. That usually happens in the temporal area. It's associated with aching or burning around the temporal sites. And a lot of the times they lose vision. Again, this is an emergency. Okay, so secondary causes of headaches. So another secondary causes of headaches should be quickly ruled out. We want to assess for associated symptoms like fever, neurological changes, like the worst headache ever, like I mentioned before, pain at the temples, and vision loss. So reasons for other causes for headaches that you want to rule out quickly are tumors, stroke, infection, metabolic, trauma, subdural hematoma, subarachnoid hemorrhage, Barry aneurysms, and temporal arteriitis or giant cell arteriitis. Again, if in doubt, consult immediately, and if suspected any of these things, you need to transfer them to the emergency room immediately. Red flags indicative of a secondary problem include progressive or fundamental change in the headache that worsens over time. Again, if the patient states, "This is the worst headache of my life," we're in trouble. You need to call 911. New onset headaches before the age of 5 or after the age of 50 are a concern. Persistent headache precipitated by a Valsalva maneuver, exertion, or sex, those are all a concern because it's just something with pressure in the head that's causing that headache. We want to make sure that that is addressed immediately. Any headaches with fever, acute glaucoma, hypertension, myalgias, weight loss, or scalp tenderness, all concerning. Neurologic signs and symptoms that would be concerning as well, and red flags would be confusion, altered level of consciousness, changes in memory, papilledema, sensory deficits, reflex asymmetry, or gait disturbances. Obviously, a headache with syncope or seizures is also a big red flag. So here's your red flag list, just to give you like some major signs that need to be addressed immediately. When it comes to headaches.
It's
so
12 o'clock.
Rapid onset of symptoms, thunderclap headache, presence of neurological symptoms, prominent neck pain with or without fever, age at onset greater than 50, you always want to consider giant cell arteriitis, worsening with positional changes or Valsalva maneuver, or newer worsening headache in patients with history of migraines. All right, these are all red flags list. Headache differential. So when it comes to headaches, what else are we considering? So you want to consider the diagnosis from the 3 main categories of the headaches: tension, migraines, or cluster. You want to consider your secondary causes: space occupying the lesion, bleeds, meningitis, temporal arteriitis, CNS infections, brain abscess, carotid dissection, all of those things on the algorithms you saw from the previous slide. You want to consider other medical conditions such as sinusitis, TMJ. TMJ is a big one in terms of causing headaches. It's when you grind your teeth, that a lot of patients with TMJ will wake up with severe headaches. So that's something, if that's the cause of the headache, then of course you want to refer them back to their dentist. They need to be fitted for a night guard to help prevent that grinding. So again, medical conditions that would also be differentials would be hypertension, thyroid disease, asthma. If the patient has had any recent procedures or other causes that it might be, could be spinal anesthesia, medication side effect, or overuse, illicit drug use, caffeine excess, caffeine withdrawal, headaches associated with sexual activity like post-orgasm, eye strain, and many other causes. So those are all other differentials you may want to consider with the headaches. But understanding these differentials it's really important to kind of think about this when you're assessing your patient, because it also gives you more avenues of questions to ask and things to consider that the patient may not have even considered. Headaches. So diagnostic reasoning. We want to first start by listening carefully to the patient's explanation of history and elicit HPI and review of systems. So are there potential clues to a serious underlying condition? You want to consider the SNOOP mnemonic. SNOOP mnemonic to rule out a central cause. So SNOOP, systemic signs or symptoms. N, neurologic exam abnormalities. So when you did your neuro exam, was something off? O, onset, was it abrupt? Or O, onset from what age? Is it less than 5 or greater than 50? And P, prior history different. It's a nice little mnemonic to use when you are doing your headache diagnostic reasoning. Again, that's SNOOP, systemic signs, neurologic exam abnormalities, onset abrupt, onset of age, and prior history, any different. So if you're considering a secondary cause, does this require an emergency transport to an emergency department? So again, your red flags are what are going to tell you that. If there's no indication of traction headache or secondary cause, listen and assess for any other identifiable cause on subjective or objective causes, such as sinusitis, TMJ, or low blood sugar. Treating the cause obviously often treats the headache. So sometimes the headache is a symptom of something else. If we could treat the cause, obviously the headache's going to go away. If it's not an identifiable cause, you want to consider it that the headache is either tension, migraine, or cluster in nature. So your physical exam of your headache should be age appropriate. You want to check vital signs, of course. You want to do a detailed neurological exam, especially if the patient is unknown to the provider or if there's any change in their headache pattern. You want to check their you do a neurological exam. You want to check deep tendon reflexes, sensation, and motor function. You want to be very careful checking the head, the neck, the upper back, the shoulders, see if there's any trigger points that would exacerbate their pain or their headache. Make note of that for sure. You want to do a cardiovascular pulmonary exam, check carotids, check their temporal artery palpation. You want to look at their skin for any systemic rashes, and you want to do a fundoscopic exam to assess for papilledema, which is suggestive of increased intracranial pressure and other etiologies that would swell the optic nerve, which would likely cause a significant problem when accompanied by a headache. All right. So here in this particular diagram, you can see the swollen optic disc, which would obviously cause papilledema and lead to a headache. So common headache diagnostics include MRIs, CT scans, ESR and CRP, a CBC with a metabolic profile, and a urinalysis, all to check systemic causes. Keep in mind your vascular biopsy is a gold standard in diagnosing giant cell arteriolitis. If you consider that your patient might have giant cell arteriolitis, again, that's a red flag that needs to be addressed immediately, and they do need to go to the emergency room. When you want to order your MRI for your headaches, things that you need to consider in terms of when to order the MRI is if the patient has a change in the pattern of their headaches, obviously if they've had any seizure activity, or if they have a new onset of migraines, specifically in your older adult population. Because again, in the older adults over the age of 50, that's when we worry about the GCA. So your tension headaches, this is the most common headache type. Your risk factors, usually it's more female than male that get it. There's a high incidence in Caucasians and a high incidence in people with higher education levels that get these types of headaches. 40% have a familial component, and it's usually the muscle contraction headache may either be primary with no underlying pathology or secondary due from the results of trauma, infection, arthritis, or maybe a tumor. In terms of diagnosing, you want to differentiate between other headaches and secondary causes and traction headache. It may be related to other conditions such as hypothyroidism, hypertension, and asthma, chronic overuse of NSAIDs, Tylenol, caffeine-containing compounds. Signs and symptoms might be mild to moderate pain, constant bilateral head tightness, which can last an hour, half an hour to a week, non-pulsatile, and does not cause nausea, usually not made worse by physical activity, squinting, or less likely photosensitivity. It may occur repeatedly, gradual daytime onset, more common with depression. There is some muscle tenderness believed with the head and neck pain circuitry. And with the exam, of course, you want to do a neural exam with motor, sensory, and musculoskeletal to the upper back, necks, and shoulders. Again, look at those trigger points. You want to examine your face, the sinuses, the scalp, and the temples to rule out other causes. It's very important. You know, you take the fingertips and you examine the face by gently pressing around the eyes. Okay, and the temporal areas. In terms of diagnostics, you may not need any unless the other secondary causes are suspected. So in terms of treatment for the tension headache, you want to individualize the plan, help identify the cause, and avoid and reduce triggers like stress. So easier said than done, right? You want to prescribe Tylenol, NSAIDs, cool compresses, and stress reduction techniques. These patients, you want to talk to them about things that are stress reducing, like walking on the beach or doing yoga or meditating. You know, these are things you may want to consider offering them, you know, a couple of times a week so that they can start to figure out a plan to how to reduce this themselves. You could prescribe a combination of butalbital, 50 milligrams with Tylenol, 325, and caffeine, which is known as Furacet. That's more for your chronic tension headaches. Again, they may use various alternative things like stress, yoga, meditation, massage, biofeedback modalities, trigger point injections for chronic muscle tension, and of course, treatment for any underlying mental health disorder like depression and anxiety. Migraine, this is the second most common headache type, the third most prevalent disorder, and the seventh highest specific cause worldwide disability-wise. There are two types of migraines, one with aura and one without aura. So symptoms of aura develop gradually, usually followed by headache. Auras are fully reversible and last 5 to 60 minutes. Then you have a migraine without an aura. So there's no symptom that would give you the heads up that a migraine is coming. And then you have chronic migraines classified as that they occur at least 15 days in the month for more than 3 months at a time. So that is what you need to have documented in order to classify or diagnose this patient with a chronic migraine. So it's classified as occurs on at least 15 days of the month for more than 3 months. All right. That's the criteria to diagnose chronic migraines. So just keep in mind migraines with aura. I had a student at my quite a few students who got a lot of migraines when I was a school nurse. And it was interesting, quite a few of them did get the aura. And right as they were getting the aura, they prepared themselves by having a trash can nearby because they knew they were going to vomit. That's the severity and how quickly it happened. It usually would take between 5 to 10 minutes before the vomiting would occur. And I didn't realize how serious this was until I had about a 8-year-old come in, or maybe he was 9, and he was complaining of the headache, and I thought he was just trying to get out of class, and I sent him back, and within 5 minutes I get a call. He vomited all over the stairwell. And I was like, oh, now I know what that means with the aura. So always make sure you take that into account and document it, okay? So diagnosing migraine types, migraine with aura, it must include the presence of one or more fully reversible neurologic symptoms. So that could include visual, motor, sensory, speech, brainstem, and retinal. Migraine without aura, it must include 2 characteristics. It's unilateral in location, pulsating quality, moderate to severe in intensity, and it's exacerbated by physical activity. And at least one of the following must be present, and that's nausea and vomiting, or photophobia or phonophobia. So migraine without aura, it's the more common type of migraine. It's very predictable in its patterns. Prodrome, it's drowsiness, depression, euphoria, hyperactivity, difficulty concentrating, irritability, and an increased sensitivity to noise, light, or smells. It's followed by a unilateral throbbing pain accompanied by anorexia, nausea and vomiting, sensitivity to noise, lights, and smell. Hypersensitivity may make normal pulsatile blood flow painful and appear exaggerated, which can affect the same side as the trigeminal nerve. So that normal pressures like combing your hair, shaving, taking shower, and glasses or earrings on the face and scalp can even feel painful. Signs and symptoms are moderate to severe unilateral pain lasting hours to days. It's throbbing and pulsatile in nature. It causes nausea and vomiting and often is made worse by activity. It occurs repeatedly, average 1 to 3 times per month. So to be honest with you, besides the aura piece, all the headaches kind of have similar things in that they're very painful. It can last a certain amount of time. They are very sensitive to noise and touch. So these are all very typical of your basic symptoms of a migraine. So the less common types of migraine have the aura, and it's a sensory phenomena. What is an aura? Sensory phenomena, usually a set of patterns in the visual fields, sequence of strange feelings moving from the hand up the arm and onto the face. Complex auras can cause focal neurological signs such as hemiplegia, paresthesias, and aphasia. An aura phase may include euphoria, depression, fatigue, hunger, and hypersomnia. Aura develops over minutes and usually lasts less than an hour. It's typically followed by unilateral throbbing headache, although a headache may start before at the same time as the aura. So migraine triggers. So there's a few different things, obviously, that can trigger the migraine. Hormonal, environmental, like noise, hormonal being low estrogen levels, dietary, like alcohol, sodium, vasoconstricting things like caffeine, tyramine foods, phenethylamine, which is in some cheeses and red wine, and MSG, which you find a lot in Chinese food, frozen foods, frozen dinners, canned soups, and artificial sweeteners. Activities like stress, a lot of sports, weightlifting, running, inadequate warm-ups, physical activity at high altitudes, extensive cycling, climbing, skiing, all those things that are at different altitudes definitely can lead to migraines. Other things, fatigue, changes in sleep schedule, excessive sleep, too little sleep, cigarette smoking, and dehydration also can all lead to migraine, are all migraine triggers. So migraine subjective and objective data. So things you want to inquire about with the patient. So you want to ask them, do you get an aura? Do you get any kind of strange, consistent feeling before the headache comes on? Prodromal, like how do they feel right before it happens? Or before it happens, are they getting tired? Are they getting anxious? Tell me what precedes the actual migraine. You want to ask about the onset, the quality of pain, associated symptoms, any triggers, any kind of food that they eat that they've noticed before they get the headache or the migraine that they eat and then suddenly it comes on. You want to definitely ask your female patients about their menstrual cycle. Does the headache come and go with their ovulation cycle? Is it post-menses, during menses, any other associated GYN disorders or oral contraceptives? Are they taking birth control? Birth control can definitely be a trigger for migraines. It changes their hormones. Age onset. Females often have their first migraine at the age of menarche and stop during pregnancy. It's, usually it's unilateral throbbing and it can lead to anorexia, and symptoms should include, definitely can include nausea. Your exam should not reveal neurological deficits. If it does, something is wrong. Now we know where to lead our diagnostics and look back at that algorithm to distinguish what exams need to be done again. Next, if the patient is in discomfort at the time of exam, you may see photophobia and vomiting. You may need to defer a full physical exam if the patient has the migraine at the time of the visit, because you need to balance the visit against the need to rule out conditions that may be part of the migraine and may be red flags that need to be addressed quickly. It can be a challenging diagnosis to deal with if it's a new onset and it's a new patient, because you will have to be able to differentiate if this is a migraine versus traction or other secondary cause of a headache. So just keep that in mind. If this is a new patient, you've never seen it before, and this is a new headache, you're going to need to take your time to figure out what's going on. So non-pharmacological treatments for migraines include eliminating the known triggers, maintaining a strict schedule for sleep and meals, adequate warm-up before working out, biofeedback, relaxation techniques, regular aerobic exercise, deep breathing, massage, meditation, hot or cold therapy, and caffeine, which can sometimes backfire. But sometimes caffeine can actually help with migraines. In terms of prophylaxis or abortive, most require a combination of abortive, meaning you treat the pain in the moment, and prophylactic, meaning you prevent it from occurring. NSAIDs and triptans are a common first-line abortive treatment. And if incapacitated from pain, some may seek care in office or in the emergency department. So in terms of that, if the patient becomes incapacitated from the pain of the headache, they do need to seek care, either to you or to the emergency room. Again, if headaches start to become so severe the patient can't function, something is wrong, it needs to be addressed. So in terms of treating migraines, finding the right medication can be a trial and error. You know, what works for some doesn't always work for others. You want to start with considering the side effect profile, the cost, and the ease of use for this particular patient. Look at what their insurance covers and look at what the patient is willing to deal with in terms of side effects. See list of pharmacological agents in table 6.1. So abortive therapies include triptans, which are serotonin receptor agonists, which are very common. Again, Imitrex and Zomig are also common, but be very careful. They are contraindicated in ischemic heart disease or other significant cardiovascular, cerebral vascular disease. They may need to see providers perform or review an EKG on hand prior to initiating if the patient is not known to the practice. Some side effects include paresthesias, nausea, dizziness, chest or neck tightness, heaviness, or somnolence. A risk of rebound headache if triptans are used more than twice a week. Imitrex is frequently used due to the use as a nasal spray. It might be easier, and it's also an injectable. Okay, so more about abortive therapies. So we have our ergot derivatives, NSAIDs, antiemetics, opiates, and combination medications, which you talked about before with Furosep. So prophylactic migraine therapies also include beta blockers, calcium channel blockers, antidepressants, and anticonvulsants. But you have to be careful with these. Some of them, they're contraindicated, like calcium channel blockers are contraindicated in pregnancy. Beta blockers are really preferred if the patient is hypertensive or has angina, like Inderal, but it's contraindicated in asthma and sinus bradea and AV block. And it's potentiated by alcohol. So you got to be very careful because, you know, you got to make sure you look at your patient's history and also their social history currently. Migraine treatment summary. So we want to diagnose, we want to treat, we want to remember that early treatment and prescription, diagnostics improves outcomes. You want to definitely consider a neurological referral. You want to work with the patient and the patient's family to identify triggers. You want to have the patient work on developing a headache diary just so they can really start looking at common triggers, commonalities that might be leading to the headaches. You also want to have them document like what they're eating around the time of the headache or before, as well as what's caused, helping them dissipate the headache. What makes it go away? What did they take? How long did they sleep for? Like what was the amount of time and what did they do to make it better? It often requires 2 to 3 different medications and lifestyle changes. Obviously, the migraines can be very debilitating and you don't want to wait for vomiting to occur because obviously that pressure is going to make the headache worse. So you definitely want to treat any kind of vomiting aggressively. In practice and what's new. So there is evidence on many of these that they can help and are helpful for some suffering from migraines. So in the table on 6.1, you can see Botox, supplements, and herbs like magnesium, coenzyme Q10, butternut root extract, riboflavin, feverfew are used frequently by providers and patients, and they act as good alternative methods to help manage the headaches. So in terms of referring to neurology, these are the patients you want to refer patients with episodes of transient neurological deficits, difficulty managing the migraines. In practice, you frequently see patients being connected somewhat routinely with neurology if triptans and or prophylaxis is required. So if you're writing those prescriptions, you just want to automatically refer them to neuro. Obviously, you're going to refer to neuro if the headaches increase in frequency and severity of unilateral headaches or atypical auras. If there's any changes in the patient's personality, excessive sleepiness, new onset of progressive deficit suggesting a mass lesion, hemorrhage, or structural disorder. If we suspect giant cell arteritis, and of course, if there's a surgical referral for any temporal artery biopsy and definitive diagnosis. And of course, if they need to use, chronic steroid therapy. So in practice, headaches in the older adult, remember this, it is not just common for the older adult to suddenly develop migraines or new onset of headaches without some pathology. We really need to consider other etiologies and have a low threshold for consulting, imaging, referrals, and emergency room transfers. So cluster migraine, also known as the suicide headache. It's thought to involve deficits of cells in the hypothalamus, and it causes excess activation of trigeminal autonomic system. So if it's clustered, it may have in groups, days to weeks, then disappears for years, often begins a similar time of the year. So if you have a genetic predisposition, it's usually a first degree relative. Males tend to get it greater than females, and maybe it might just be because it's underdiagnosed in females. Middle-aged males with a history of tobacco and heavy alcohol use tend to get these particular headaches. It's rare in children. It's described as some of the most severe pain, like a hot iron piercing my eye. Okay, usually remember, cluster migraines tend to happen over the eyes. And they may present to the emergency room looking for any relief, and they sometimes are characterized by coming in just holding onto their eye, looking for any kind of relief. So there is a typical cluster migraine looking face with a drippy nose, watery eye, drooping eyelid. They're often awakened at night with unilateral retroorbital pain. The pain may be rapid onset and intensity from 60 minutes to 3 hours. It can occur multiple times a day, may remit and return months, years later. You're usually restless, unilateral tearing, rhinorrhea, severe pain, and a drooping eyelid. Treatment includes high-dose NSAIDs, opioids, triptans, high-flow oxygen, 6 to 12 liters for about 15 minutes can be very effective. Prophylaxis would include verapamil and, of course, lifestyle modifications. So giant cell arteriitis, it's a systemic inflammatory vasculitis of unknown etiology, also known as temporal arteriitis, arteriitis cranialis, Horton's disease, granulomatous arteriitis, and arteriitis of the aged. Most important for you to remember is giant cell arteriitis. It affects the temporal artery, so think the temporals on either side of the head. And it's most common form of systemic vasculitis in the adults, and it may result in bilateral vision loss, considered an emergency. So if somebody's grabbing the side of their head and say it's going to explode, or they have the worst headache ever, again, 911. Usually, again, they present with visual disturbances, jaw claudication, neck pain, scalp tenderness, fatigue, malaise, fever, tender scalp. Jaw claudication is usually the highly indicative, and they get tired of their muscles from their mouth from chewing actually get tired. So jaw claudication is highly indicative. As the disease causes widespread vasculitis, presentation can vary, including symptoms throughout the vascular system. So in the GCA, giant cell arteriitis exam, you need to do a thorough neurological exam of the head, neck, ophthalmic, vascular, and blood pressure in both arms to rule out aortic arch involvement. And you need to listen for bruits throughout the body. You may see a variety of changes, including cranial nerve palsies, tenderness to any artery, and palpation of temporal arteries should always be part of a head and neck exam. Usually you're going to feel tenderness to palpation or visible swelling of the vessels. That may be indicative of giant cell arteriitis. Remember, you need to palpate, you need to touch your patient. Okay, so in terms of treatment and referrals, you want to get immediate consultation and referrals from vascular surgery for temporal biopsy, a rheumatologist for treatment, and ophthalmology as well, just to get their eyes checked on and dealt with if there's any visual changes. Temporal artery biopsy is definitive, but we do not wait until the biopsy to begin steroids. We start the steroids immediately to preserve the vision. We also want to do blood work, check their ESR, CRP, and again, large doses of steroids for treatment. So differentiating headaches from other neurological conditions, again, cluster, this is just to differentiate. So this is what we've talked about so far. So cluster migraines, extreme severe unilateral eye pain with eyelid drooping and rhinorrhea, migraine with or without aura. It's unilateral pulsatile throbbing pain, nausea and vomiting. They should not have any neurological changes. Bell's palsy, usually no rhinorrhea, no severe eye pain, and there is facial drooping and a loss of nasolabial fold. So you'll just see a sudden drooping of their face. Versus cluster migraine, you're going to see a little drooping as well as runny nose and teary eye. CVA can present in many ways. Typically do not see the severe unilateral eye pain. There may be or may not be drooping associated with the CVA. The CVA may have an extremity cognitive changes. Do not see this in a cluster migraine. And then, of course, the last but not least, giant cell arteritis, what we've just been talking about. It's usually got that temporal tenderness. So when you palpate and press against their temporal area on their head, on either side, you're going to feel tenderness, possibly even swelling. They do not have an aura. They may have ophthalmic changes, and you do want to consider this in an older adult with a new onset headache. Anybody over 50 who suddenly starts getting a headache, especially around the temporal area, consider this diagnosis. Okay, headache workup, when to scan. So neuroimaging is not required for all patients if they're stable, if there's normal exam, no seizures, no imaging is required. You want to perform a CT or an MRI if it's unstable, changed headache patterns, or it's the worst headache ever, or if they have neurological changes, or if this is a new onset and advanced stage. The challenge is if a patient has a headache history and then develops a secondary or other condition that gets chalked to the headache, you need to be alert each time you see a patient for changes. Patients can have more than one problem, and most do, okay? Most do, especially nowadays. Anecdotally, if a patient gets a referral to neurology, they often will do an MRI. Labs are often not required, although they may be drawn as baseline, or if you're considering an underlying etiology like a CBC, drug screen, metabolic panel, thyroid, SED rate, that kind of thing. You also want to make sure if it's a female, you're checking if they're pregnant. And EEG is not particularly useful here. So paresthesia and paresis. So paresthesia is an abnormal sensation described as numbness or tingling, cramping, or pain without a known stimulus. It's felt along the peripheral nerve pathways, and it's complaining of annoying pins and needles. Paresis is weakness, which may develop suddenly or gradually and may be permanent or transient. The most common diagnosis associated with paresthesia symptoms are arterial occlusion, arterial sclerosis obliterans, and nerve entrapment syndrome, neuropathy, TIAs, and herpes zoster. Arterial occlusion is a surgical emergency. Just keep that in mind, okay? Again, here is another beautiful diagnostic reasoning algorithm for paresthesia and paresis. So you're differentiating your symptoms because, again, these are two very broad, common symptoms that you need to differentiate, what the causes are before you, progress with your treatment plan. So is it from neuropathy? Is it from herpes zoster? Do they have shingles? Do they have a TIA? Is it an arterial occlusion? Because all of these are very different in their treatment plans. This particular, we're going right to the emergency room. So tremors. Tremors typically are in patients with cerebellar or extrapyramidal disorders, and it can be also from side effects with certain drug regimens. Tremors can be classified into 7 groups. We have physiological, essential, toxic, cerebellar, Parkinsonian, I'm sure you've all seen that, resting tremors, and intentional tremors. As the most common movement disorder, it is apparent in 1 to 20 Americans older than 40 and 1 in 5 older than 65. So when you're examining your patient with tremors, you want to do a complete musculoskeletal and neurological exam to assess range of motion, mental status, strength, sensitivity, cranial nerve function, deep tendon reflexes, and gait. Important, you want to note when the tremor is present, whether it's present with rest or activity. Which part of the body is affected? Is it bilateral or unilateral? Is it happening only in one hand or is it happening in both hands or one leg or both legs? Type of movement that's produced by the tremor. Is it with flexion or extension, pronation, supination, or pill rolling? So when they put their hand out, is it facing down, facing up? Are they moving their fingers and suddenly they start to tremor? When is this happening? You need to look at what you're seeing and document it, okay? Assess the muscle tone. Is it normal or increased? Check their speech, their gait, and their posture. You want to do a thorough drug history. That's essential, including any over-the-counter medications. You want to note whether the tremors are affecting the patient's ADLs or their gait, and have they had any recent falls because of it? Or not even just because of it, have they had any recent falls? Because a lot of the times the patient won't associate the tremors with a fall, but the likelihood is it's probably throwing off their gait. So we want to understand if they're having falls, then we know that the severity of their tremors is actually worse than we probably realize, or worse than the patient realized. Any history of family members having tremors. A review of systems may also disclose endocrine, metabolic, or neurological disorders. Again, another beautiful algorithm to differentiate your tremor causes. So remember, tremors can be benign, essential or indicative of serious conditions like Parkinson's or most MS. You want to refer to neurology. So here are all possible, things they were circled here in this algorithm because I thought it was so important to just really make sure you grasp these could be all potential reasons for your tremor. So Parkinson's, panic attacks, toxic conditions like antipsychotic drugs, too much caffeine, benign essential tremors, hypoglycemia, multiple sclerosis, or cerebellar. Of course, you want to refer to neurology. Alcohol withdrawal is a big one. Metabolic imbalances like drugs, caffeine, and psychological fatigue or physiological fatigue. Okay, Bell's palsy. This is a scary one. Sometimes you think this and you think stroke, but it's acute onset. It's unilateral, one side of the face. It's cranial nerve number 7. That's palsy. You have the loss of nasolabial fold. Over here, you have a drooping lid. Over here, and a drooping mouth. So you will classically see this presentation with Bell's palsy. It's common in men and women, but it has an increased incidence in pregnancy in the last trimester. It's cranial nerve number 7, which is affected. So if you just know cranial nerve 7 equals Bell's palsy, like that 100% will likely come up on the boards or some exam at some point. The patient may have ear pain preceding onset by 1 to 2 days. It's usually rapid in progression. The maximum paralysis is within 48 to 72 hours. They have like an abnormal sensitivity to sound. They may have decreased hearing, ringing in the ears, hypersensitive to region. Taste changes, tearing, and drooling may occur. There are no other neurodeficits noted. This is important in how you can differentiate it from a CVA. All right. It often follows a viral illness such as an upper respiratory infection, shingles, Lyme disease, diabetes, or HIV. So that's what you want to consider. So it usually follows the viral illness, like the upper respiratory and shingles, but the other things you want to consider are Lyme's and diabetes and HIV if they're having any of these things. So tests for Bell palsy include the following muscle tests. So forehead wrinkling, eye closure, wide smile, whistling, and blowing. Okay, this will really give you a full exam of the quality of their muscles, because what happens with Bell's palsy, one side of the face is not going to be able to do what the other side is. Diagnosis is usually made by your H&P presentation and a need for a full neuro and head and neuro exam. It's important to rule out a CVA and TIA, obviously. You may see a CBC, Lyme titer, HIV, CT, MRI of the head, and pregnancy test. So other things to consider is that undiagnosed HIV, tick bites, Lyme disease, and diabetes are associated with Lyme's disease. With Bell's palsy, that's a mistake in there. Labs are often done to rule out these entities. In many cases, the cause is unclear. It has been known to occur from having the car window open and cold air being forced on the face, as well as trauma, shingles, intracranial, and vascular lesions. So eye protection. So the single most important goal to protect the eye in terms of any ulcers or abrasions. We want to lubricate the eye because remember, it's having a hard time closing. So we have to protect it. We have to lubricate it. And sometimes you want to do a nighttime patching where it'll help keep the eye forced shut for a bit. You want to consider steroids, 60 to 80 milligrams times 1 week, and then you taper over a week. Then we have antivirals like valcyclovir, and then NSAIDs for pain management is needed. Most people with Bell's palsy recover about 85% resolve within 6 weeks, about 3 months max. The remainder often have recurrent symptoms. They may need to do physical therapy for facial drooping, and it's better outcome if the treatment begins promptly. So herpes zoster, this is not a fun thing to get. I'm sure you've seen your patients present with this. It's a reactivation of varicella virus. It's a vesicular rash along a unilateral dermatome, commonly in the intercostal areas, such as the trunk or the face. You cannot catch shingles, but it may be contagious to those who have never had chickenpox. Usually in the older adult, it can reoccur. And keep in mind, it does not cross the midline. So you're going to get on one side. If it's on the other side, or it's on both sides, it's not shingles, something else. It may also cause encephalitis, neuropathies, and Reyes syndrome. And definitely there is something called post-herpetic neuralgia. This is a chronic pain condition that occurs in a large percentage of patients who experience shingles or herpes zoster. They get this pain after it's already, the blisters have gone away and resolved. They still have pain for about 6 months afterwards. It's pretty bad too, especially in the elderly. Oof, it's terrible. So this is what it looks like. Remember, we said it's unilateral, so it's on one side, this side. If it starts to cross over here, then we know it's not shingles, it's probably something else, because remember, it stays on one dermatome, one-sided. These are the little blisters. When they get into the eye, that's when we have trouble. Most of those patients are really followed closely because it can be very painful as well as cause blindness. So it's unexplained pain, maybe constant, intermittent, varying qualities. Pain usually occurs 48 to 72 hours before the rash is visible. It's a unilateral vesicular rash along a dermatome. We said that already. Erythematous base, like very red at the base, and then the vesicles appear, make coalesce. It usually lasts 10 to 15 days. Differentials could be impetigo, Coxsackie, and MRSA. So again, your treatment includes antivirals, pain meds, steroids, and Burow's solution. They may develop a secondary infection requiring appropriate coverage for SSTI, skin and soft tissue infection like Keflex or Bactrim. Herpes zoster ophthalmicus is this a zoster in the fifth cranial nerve, trigeminal. It's a stat ophthalmology referral, which may lead to blindness. These patients often have a lesion on the tip of their nose. Post-herpetic neuralgia. Again, chronic pain once the rash is gone, but the pain persists for about 3 months. This can be debilitating. So you may need to send the patient to pain management if they're unable to control the pain. Usually these patients are typically prescribed Neurontin, frequently throughout the day, lidoderm patches, capsaicin, and you want to make sure you're treating the zoster aggressively to reduce the incidence of PHN, or post-herpetic neuralgia. So get them on those antivirals immediately. The sooner they can get that out of the system, the better off the patient is. Here are your patch treatments in terms of pain management. These patches are great. I will say though, they work really kind of, just really close to the site of where the pain is. So sometimes it's good and sometimes it's not enough. Okay, seizures. We're going to talk about the types, the management of, exam of diagnostics, and the patient education, and then that's pretty much it, guys. So we're almost done. So seizures. So let's look at the risk factors. Usually occurs in families. Parents, siblings, and offspring of a patient with a seizure disorder are more likely, 3 to 5%, than the general population to have a seizure disorder as a result of both genetic and environmental causes. So epilepsy usually affects about 2.5 million people in the US. They're common and affect 8 to 10% of people during their lifetime. They occur as a result of severe head trauma, central nervous system infections, mesial temporal sclerosis, and strokes. Children with brain injuries present from birth, such as those with cerebral palsy, and they are definitely at higher risk for seizures. Children who are intellectually challenged and have a positive or negative genetic disorders are also at increased risk for seizure disorders. And when both conditions exist, greater than 50% affected may develop seizure disorder by the age of 20. Although most children with a history of febrile seizures do not develop epilepsy, there is a slight increased risk for developing a seizure disorder during their lives. So seizure classification. So we have partial and we have generalized. Partial seizures are seizure activity that originates in one part of the brain. That can break down into simple or complex. And then we have generalized, which is seizure activity involved in the entire brain. And those seizures tend to fall in the higher end of tonic-clonic type seizures. So remember, your seizures are classified in terms of absent, myoclonic, tonic-clonic, tonic, or atonic. So provoked, unprovoked epilepsy. So provoked seizure is caused by an underlying medical condition. It may never reoccur or require treatment beyond treating the underlying medical condition. We hope, for the sake of your patient, that it's more of a provoked seizure than an actual epilepsy. to be quite honest. Causes can be febrile related. If it's a provoked seizure, some of the causes can be febrile related seizure in infancy, meaning they had a really high fever when they were a baby, so it caused a seizure. Trauma, hypoglycemia can cause a seizure. Hyponatremia, low sodium can cause a seizure. Hypocalcemia, low calcium can cause a seizure. Drug abuse and alcohol withdrawal also can often cause seizures. Most often, these generalized seizures are tonic-clonic seizures. Keep in mind, epilepsy is a condition in which an individual is predisposed to seizures and has had 2 or more unprovoked seizures during their lifetime. So in order to be diagnosed with epilepsy, you've had to have 2 or more unprovoked seizures in your lifetime. So manifestations, they vary and relate to the area of the brain affected by the seizure. So if we're dealing with motor activity, it's usually jerking or stiffening of a limb. If we're talking about autonomic function, we're talking about tachycardia or sweating. Vision, in terms of manifestations, we're seeing colored shapes. Olfaction, or they're smelling weird, strange odors. Language could become aphasic. They can't speak right before it happens. Psychological feeling of deja vu, like that feeling that something's about to happen that's already happened before. Sensation, paresthesias in one area of the body, and then consciousness. They may or may not lose consciousness during their seizure. So the types of seizures, we have focal, generalized, epilepsy, focal onset, or focal seizures with impaired weakness, previously called complex partial seizures. This is the most common type of seizure in adults with epilepsy, and they usually appear awake, although they're not aware of their surroundings. They do not respond appropriately to others, and they may be associated with repetitive behavior. It's called automatisms, such as chewing, lip smacking, repeating words, or gestures. It may begin with a focal seizure with preserved awareness, aka a seizure aura or simple partial seizure. Focal onset seizures may progress to a generalized seizure called a focal to bilateral tonic-clonic seizure. So here's how we differentiate in terms of focal onset, generalized onset, and unknown onset. So this just gives you kind of a layout of how to classify all of them in terms of motor versus non-motor symptoms. So generalized seizure types. We have generalized onset seizures, which begin with generalized abnormal electrical activity, which include generalized tonic-clonic, absence, myoclonic, tonic, and atonic seizures. Generalized onset seizures are associated with childhood onset generalized epilepsy syndromes. And since both hemispheres are involved, consciousness is typically briefly impaired, except in myoclonus. So keep that in mind. Most of your patients who go through seizures, they have a moment where they lose consciousness. They don't know what's going on. Motor manifestations are bilateral. The EEG shows bilateral and widespread seizure activity in both hemispheres. So most seizure types. So these are the seizure types. This is very important for you to be able to differentiate. So an absent seizure is a non-motor seizure causes sudden interruption of ongoing activities, typically with a blank stare. So if speaking, the speech will be slowed or interrupted. If walking, he or she will seem transfixed. If eating, the food will be stopped on the way to the mouth. Typically lasts a few seconds. So these seizures, the patient looks like they just blanked out for a minute and they're like in a different zone. And it's just for a second. That's an absent seizure, meaning it's like it didn't even happen, but it happened. Then we have our tonic-clonic seizures, which used to be referred to as grand mal seizures. Okay, grand mal, I'm sure you probably have heard of that. It's most frequently encountered in generalized seizures. Like it's a sudden tonic stiffening of the muscles, often with stridor or an ictal cry. Patients fall to the ground and the tonic state lies rigid during the state. It inhibits respiration and cyanosis may occur. The tongue may be bitten. They may involuntarily void. They have clonic convulsive movements lasting a variable period of time, and deep respiration will occur and all muscles will then finally relax. So it's a scary thing to see this type of seizure. The important thing is education, especially with the caregivers of these particular patients, how to manage these seizures. So I'm sure you've known this from your RN days, but just as a review, the biggest thing is we want to get them on their side and protect their head when they fall to the ground. So try to get a pillow under their head or protect their head with your hands so that as they're seizing, their head doesn't continually hit the floor. And if they vomit, which they may very well do, you have them on their side so that they don't choke. And then of course you want to try to clear the area, call 911, give the patient privacy, because again, they very well may either urinate or have a bowel movement during the seizure. I've seen it happen more than once. In the postictal period following a tonic-clonic seizure, or also known as a grand mal seizure, they may have a depressed level of consciousness. They may deep sleep and then significant headache when they awaken. Maybe a generalized onset, meaning that the seizure begins as a tonic-clonic seizure or a grand mal seizure, and then progresses to a bilateral tonic-clonic seizure. So myoclonic jerks are sudden, brief, shock-like contractions, generalized or confined to the face, trunk, or to one or more extremities. It's mostly during sleep, associated with certain generalized epilepsy syndromes. And then you have atonic seizures that are caused of sudden loss of muscle control. Tonic seizures cause sudden muscle stiffening, like your grand mal. Your grand mal seizures cause sudden tonic stiffening of muscles, versus your atonic seizures causes a sudden loss of muscle control. Both are associated with generalized epilepsy syndromes and cause drop attacks, like sudden falls without warning. They typically begin in childhood and can lead to injuries. So in grand mal seizures or tonic-clonic, they get suddenly stiff. In atonic seizures, they become suddenly loss of muscle control. So atonic versus grand mal or tonic-clonic. Psychogenic non-epileptic seizures, PNES. So paroxysmal seizure-like events arise from psychological disturbances, not abnormal electrical brain activity in this particular type of seizure. Up to 80% of PNES are associated with early sexual abuse, especially females. So this is almost like a post-traumatic way of the body developing seizures to deal with some past sexual abuse that never got dealt with. They used to be called pseudo seizures. They do mimic true seizures, so confirming the diagnosis is key. PNES is often distinguishable from epileptic seizures by H&P during an event, but EEG monitoring usually is required for accurate diagnosis. PNES are often comorbid with epilepsy and considered a type of conversion disorder. During a non-epileptic seizure, the EEG will be normal. So subjective evaluation for seizures. So we want to get a detailed history. Again, what are your precipitating factors? Behaviors exhibited just before the event? Did they get an aura? During the event, did they have ictus? Did they have a postictal phase? How long did the seizure last? Was there a loss of consciousness? Did you feel dazed? What do you remember during, after, and before? Was there any injury to the head, tongue biting, anything like that? Any injury to the teeth? Was there any prior history of seizures prior to this episode? Any past medical history of seizures? And of course, is there any family history of seizures? Any medications? Is the patient on any medications? Do they have any allergies? Do they use any drugs recreationally? Any herbs? Do they take any herbal supplements, over-the-counter supplements, vitamins, diet pills, energy drinks, anything of that nature? You want to be sure to ask others, as the patient may not be able to give the answers. So get to family involved if you can. So we want to look at their differential diagnoses with seizures, of course. What are things that you would consider besides just epilepsy or seizure disorder? You're looking at syncope, PNES, a CVA, psychiatric disorders, brainstem issues, sleep issues, metabolic issues, infectious disorders, headaches, or movement disorders. If it's the first time that a patient has had a seizure, the diagnostics you need to include in your exam include EKG, a CBC with differential metabolic panel, electrolytes, liver function test, serum calcium, urinalysis, drug screen, or blood alcohol level if appropriate. You want to look at the blood levels if the patient is on anti-seizure medications. If first-time seizure does need brain imaging, whether it's a CT or an MRI to evaluate for structural lesion, examples such as a hemorrhage or a tumor as an etiology. Super important, guys. We want to make sure we're ruling out any kind of bleeding or brain tumors. An MRI provides a more detailed view of the brain than a CT scan and may reveal more subtle seizure foci, such as a mesial temporal sclerosis, which may be missed on a CT scan. A CT is valuable if it's trauma or new onset and considering there's a bleed. If you want to consider if there's a bleed, you look at the CT. An EEG is usually done outpatient. So between seizures, an EEG can support a diagnosis of epilepsy if the epileptiform discharges are present. And it may differentiate between focal onset and generalized onset epilepsy. And of course, big time, if you're considering that this seizure is a result of an infectious process, you want to do a lumbar puncture. So a clinical pearl to remember: a new onset provoked seizure in an adult, you must consider a space occupying lesion, AKA a brain tumor, unless proven otherwise. So if you get an elderly person or an adult over 50, 60 years old, you want to consider brain tumor until proven otherwise, especially if it's a new unprovoked seizure, especially if they're experiencing headaches or change in mental status, change in their gait, any neurological changes. Definitely rule that out first. So management. So most patients with these issues are referred to neurology to establish a medication regimen. They may require multiple classes. You want to look at table 7.1 for specific medications and side effects. Some patients are weaned off to see how they will do. Neurology is in charge of this. And if they do good, they're great. Others need to be on it for a lifetime. You never want to abruptly stop these medications, and you want to check blood levels on medications that require it. You always want to follow up and inquire about any type of seizure activity with every visit. Medications used to treat would be benzodiazepine, Tegretol, Zerontin, Neurontin, Vimpat, Lamictal, Keppra. These are the two you see a lot: Lamictal and Keppra. Trileptal, phenobarbital, you see a lot. Dilantin as well. Topamax, Depakote, and Zonegran. So of course, in terms of your exams and diagnostics, you want to get vital signs, orthostatic blood pressures. You want to do a complete exam, age-appropriate focus, note head trauma, carotids in the older patient, neck exam for stiffness. You want to do any kind of alcohol or drug testing, screening if necessary. You want to do a neuro exam. That should be completely normal in an unprovoked seizure once a person is no longer postictal. So there is a risk of seizure recurrence. So there is a strong evidence that adults presenting with an unprovoked first seizure should be informed that the chance for a recurrent seizure greatest within the first 2 years after a first seizure. So they have to be very careful. So management of an unprovoked first seizure in adults. What are we managing? What are we doing with these patients? So factors associated with increased risk for seizure recurrence include prior brain insult, like they had a stroke or trauma to the head, car accident, something of that nature, and an EEG with epileptiform abnormalities. We want to moderate evidence. Clinicians should also advise such patients that clinical factors associated with an increased risk for seizure recurrence include, and then we want to look at a significant brain imaging abnormality and a nocturnal seizure. So in terms of emergency management of seizures, this is a good little chart to use. Partial seizures, patient may resemble an intoxicated or drug person. He or she may stare without focusing or speaking, or appear to be fidgeting or smack the lips. During the seizure, you do not attempt to restrain the patient. You gently move the patient away from dangerous objects. After the seizure, you stay with the patient until the patient is fully alert and reassure others that the behavior was medically caused. Okay, so generalized seizures. If the patient gives out a warning sign, a cry or scream and falls, and then jerks their arms and legs, you want to remove the patient's glasses or lay them on their side. Do not restrain, clean the area, loosen tight clothing around the neck. Do not put any object into the patient's mouth. It used to be people would put spoons in the mouth. I don't know. Do not put anything in the mouth. After the seizure, stay with the patient until he or she is fully awake. And if the patient has a known seizure disorder, it may not be necessary to call for medical help depending on the preference of the patient and family, unless an injury has occurred. And if the seizure lasts longer than 3 minutes or a second seizure occurs, you need to call 911. Because remember, we're worried about airway, we're worried about blood flow to the heart, to the lungs, to the brain. So these are a concern. So seizure patient education, you want to recommend support groups, because obviously this can be very devastating and frightening for the families and the patient. You want to teach seizure first aid to the patient and the family and the significant others. And remember, they do not need to go to the emergency room every time they have a seizure unless they're out, they have a loss of consciousness for an extended period of time or any kind of respiratory issues. You don't want to put anything in the mouth, use recovery position, don't restrain them. Again, protect their head as they're having their muscle spasms. You want to maintain safety. You want to prevent any risk of drowning, any burns, any injury with the seizures. You want to avoid ladders. They have a serious risk of drowning with bathing and swimming. So just be very conscious of that. And they just should make sure to not go swimming or, be alone, especially in the first few months after they've had their first seizure. In terms of kitchen, you want to be very careful with burns, smoking. Encourage them that they should never smoke, or encourage them not to smoke, but they should try not to smoke alone. If on medication with required levels like Dilantin, be sure they understand what can alter this and what needs to be adherent in order to maintain this dosage and this level. You want to be very careful with ketogenic diets and vagal nerve stimulator implantation. So driving, know your state laws. Each state has different laws regarding governing the granting of a driver's license to people with seizure disorders. Most laws in most states dictate a period of time that patients must refrain from driving after they have a seizure. The US Department of Transportation has regulations that bar anyone with a history of seizures from being licensed to drive in interstate trucking. So anybody who has a seizure disorder cannot be a truck driver. Obviously, the purpose of driving restrictions is to protect the public. We don't want these patients to suddenly have a seizure while they're driving and, God forbid, kill somebody else on the road. Although only 6 states require healthcare providers to report patients who have been diagnosed with seizure disorders, all practitioners have the responsibility to advise their patients of the medical risks, legal requirements, and recommendations regarding driving. Now, that paragraph is very important because this is going to be something that you 100% document in your documentation that you educated your patient on, and you're going to also document their response in terms of their understanding and their agreement to follow through with these recommendations and requirements. Educational and support materials are available through the Epilepsy Foundation of America. So you definitely want to refer your patients to support groups, any kind of support and education these patients can get, as well as their family members, caregivers. Very, very important to let them know. Okay, more clinical pearls. Word of caution with generics. Blood level can be affected compared to the trade name, so stay with same drug when possible. Oh, that's good. Yeah, for sure. Don't stop one drug cold, taper down while tapering up on a new medication, and follow weekly while adjusting the medications. That's it, guys. Hopefully that was super helpful. We will get further into the more complicated neurological issues in FNP2, but this really goes over your basic neurological disorders, seizure disorders, your headaches, and your common neurological complaints. So please make sure you're able to differentiate between the migraines and dizziness versus vertigo, dementia versus delirium, confusion, your seizure types, your red flags to make sure you're conscious of, like your giant cell arteritis, and when to call 911. All right, have a great week, guys. Thank you, and I'll see you next time.